Happy to introduce Dr. Soslin and Cindy Altenberg, our nurse practitioner, who have come to talk to us about all things urology. Thank you all for coming, and also would you please silence your cell phones? So she'll take questions at the end, and she's got her whole introduction herself, but she's a great person. Yeah, talk to you later.
Okay, can you all hear me? Perfect. So yes, I'm Rachel Soslin. Thank you all for taking the time out of your evening to be here tonight. I'm very excited to be here. And special thanks to Kathy and to Debbie for hosting and for creating this and for you all for attending. I'm going to tell you a little bit more about me here in a second. Tonight we're going to be focused on men's health, and I could talk for hours about many men's health issues. So we had to, given time interest, kind of narrow it down. So I'm going to focus on 3 of the most common problems that I see in my clinic: prostate problems, bladder problems, leakage, and erectile dysfunction. There are many more issues with men's health and urology, and we're always happy to talk to you about those in detail. And if I had more time, I'd talk about all of them. But tonight we'll focus on those. I'm going to step back here. I'm going to move around some so that I can use a pointer and illustrate some slides as well. So, first things first, a little bit about me. I grew up in Fredericksburg, Texas, so just down the road, and completed my training in finance, my undergraduate degree in finance here at UT, before heading over to San Antonio, where I went to medical school at UT Health. And that's where I was introduced to urology. I had a fantastic mentor, and he was a urologist, and brought me into the operating room. And the thing I really liked about urology was the continuity of care, being able to operate and kind of fix problems, and the intimate relationship that I had. I think it's really unique in urology to be able to talk about some really sensitive issues and things that people aren't always comfortable talking about. And to be able to solve and work on some of those quality of life issues is something that attracted me to this field. So my goal today is to make you feel comfortable talking to me or talking to another urologist about some of these issues. I'm going to introduce Cindy here in a second, but she and I work together and really have the same philosophy of medicine, which is that we want to improve your quality of life. And so I think we can achieve that. And today I'm hoping that you feel validated and comfortable and armed with the right questions to either come see one of us or one of my partners to discuss some of these issues. So continuing on, after UT Health, I went to Vanderbilt University, which is where I did my urologic training in Nashville. And I wanted a little bit more training in the topics that I'm going to discuss tonight. So I completed a fellowship in continence, pelvic floor reconstructive surgery, and neurourology. So kind of all things that have to do with the nervous system and how they affect the bladder and the prostate. So that's my specialty training. I'm specifically really interested in those things. And then I started my practice here at Urology Austin 4 years ago in October. So I've been here for 4 years. And then just over a year ago, I was able to start working with Cindy Altenberg. She's a doctor of nurse practitioner or nursing practice. She had the highest accolades in all honor societies from Baylor University. And she is incredibly caring and empathetic. And as I mentioned, we kind of have the same philosophy of health. So we work together down at our Radham Lane office, which is just at the intersection of South 1st and 290, next to the St. David South Medical Center. So that is primarily where one of us is there, at least Monday through Friday, seeing patients. But if that's a little too far for you, we have another office that is opening just up the road, about 10 miles up the road in October. We're going to have, I think, over 15 providers from Urology Austin. This is at the Atrium Clinic, which is just going to be a little bit north on Mopac. I mapped y'all. It's 10 minutes for you to get to that office. It's 12 minutes to get to mine. But we also have 18 different practice locations, 59 providers, including nurse practitioners and physician's assistants at Urology Austin. So if I'm not your cup of tea and Cindy's not your cup of tea, we have plenty of people that can help take care of you. So all that being said, we're going to get started. Okay, so as Debbie mentioned and Kathy mentioned, we'll save questions for the end. I'm going to try to get through as much of the material as I can and pace myself in doing so, but there's a whole lot to cover. So write down those questions. I also we had a couple surveys and some patient information that I'm going to reference. If you weren't able to get all of that, I can bring more when I'm back in 2 weeks, but we'll kind of go over that stuff together. So key facts of men's health. Life expectancy for men is lower than it is for women, and you all may know that. Almost 6 years lower. And men seek medical help less than women do. The most recent data we have on this is in 2018, and the CDC reported that the physician visit rate, so how often a male or female went to the doctor, was almost 40% higher for women. And even if you take out those OBGYN appointments and pregnancy appointments, women still seek care for preventive visits almost twice as much as men. So again, my goal is to get you to feel comfortable talking about some of these issues with us. So what are we going to talk about? We're going to talk about prostate. So both benign, so non-cancerous prostate, and then prostate cancer as well, erectile dysfunction, and urine leakage. And like I said, these are the 3 most common things that come in through my doors. So what's the prostate? The prostate is a walnut-sized gland that sits at the base of the bladder. So we have our bladder here, the prostate below, and it's a 3-dimensional structure, and the urethra goes through the prostate. So I tell people to think of it like a clementine or a little mandarin orange, where you have the rind, and then you have the pulp on the inside. And if you were to drill a hole through the middle, that's the urethra. So the entire prostate surrounds the urethra, which becomes important here in a second. It produces a fluid that transports sperm during ejaculation. So sperm is made in the testicle and transported through the vas deferens. So if anyone's had a vasectomy, that's where this occurs. And then it joins this seminal vesicle to secrete fluid that then is ejaculated. So the prostate plays an important role in providing some of that fluid. It's also important because the nerves that supply erectile function sit on the outside of the prostate. So basically on the outside of the rind of that orange. So on the left, you can see a normal prostate. That's a normal bladder and a prostate with the urethra going through. When people have an enlarged prostate, when we talk about a big prostate, what we're talking about is that prostate tissue becoming big and causing an obstruction. So that's a nice open tube. This tube is compressed, and here you can see the prostate growing up inside into the bladder, and that creates problems. So what type of problems? Well, before we get there, I want you to know how common this is. 40% of men in their 50s have problems with BPH. That's what benign prostatic hyperplasia, or an enlarged prostate. By the time you hit your 60s, 70% of men have these issues. So again, this is one of the most common things that we see. If you live long enough, you probably will have some issue with your prostate and with it becoming enlarged and causing some urinary problems. But it's not prostate cancer. So what symptoms might you feel? Waking up at night to pee, sometimes some urgency, some frequency, hesitancy, standing at a urinal trying to wait for your stream to start, having to sit to urinate or push on your bladder or have to strain to urinate, a start and stop stream. All of those things can be symptoms of an enlarged prostate. Now, it's a little tricky, and part of our job is to help you figure this out, but those symptoms can be prostate symptoms or they can be bladder symptoms as well. So there is a lot of overlap between bladder problems and prostate problems, and we'll get into that a little bit later in our talk. When we talk about obstructive symptoms, those are symptoms of the prostate blocking the urethral tube. When we talk about irritative symptoms, we're talking about urgency, frequency, having to rush to get to the bathroom to pee. And there's a lot of overlap between the two because, like I said, that can be from a prostate problem or a bladder problem. So, how does this affect the bladder? You saw some pictures of the bladder on top. These pictures are taken with the test called cystoscopy. That's a camera test in the bladder. So it's a test we perform in the office. It takes about 45 seconds to a minute to do with some local lidocaine jelly, where we take a camera and we look inside the bladder. And why do we do that? We do that because your symptoms don't always reflect how healthy your bladder is. So you may have pretty mild symptoms, but your bladder may tell me a different story. So if you look at the picture on the left, this picture is a healthy bladder, and you all have, on one of the sheets, you all have a picture of this you can take home. So this is a healthy bladder. The bladder is a muscle, and if you think of it like a garden hose in a faucet, if you turn on the faucet, the urination, but you're kinking off that tube, you have to use more pressure to get water through, right? Same thing with urination. So if your bladder, which is a muscle, has to work really hard to get urine out over a long period of time, it deteriorates. It doesn't work as well. So we start to see these ridges in the bladder, and ultimately you can get bladder dysfunction where your bladder stops emptying. It just stops working. It's in these scenarios where we start to see more of the urgency, frequency, gotta go right now kind of symptoms. So my job is to catch you when you're here before we get there. So how do we diagnose BPH, or benign prostatic hyperplasia? One of the things we do is every time you come to the office, you get one of the surveys that we passed out. So if you will take a look, the front page, I think, says cystoscopy, and if you flip it over, if you flip it over, you will find a page that looks like this. So this is the International Prostate Symptom Score. This is the best validated survey tool that we have to assess for prostate symptoms. So you all can do this now or in the privacy of your own home, but if you take a look at this, we can grade you on mild, moderate, or severe symptoms for some of the symptoms that represent prostate problems. Now again, some of this overlaps with bladder problems as well, but it's a really helpful tool and it helps us gauge success. So if we do surgery or we start you on a medication or we just watch you, every time you come to the office, we can look at what your score is and it helps gauge whether or not you're getting better or getting worse. In addition, some other things we might do, we'll probably get some lab work, check your PSA. We may do a rectal exam and feel the size of your prostate or measure the size of your prostate with ultrasound. We, as I mentioned, can do surveys. We can use a little ultrasound probe and measure to make sure that you're emptying the bladder. These are all tests that we can use because the most important thing is your quality of life and making sure that you're getting sleep at night, that you're able to make it to the restroom on time, and that you're able to empty your bladder, but also that we're protecting your bladder, right? So we talked about this, cystoscopy, that some details on that procedure are on the reverse side of that survey. And all of this helps me decide, what are we gonna do about it? So for many, as I mentioned, many men are gonna have an enlarged prostate. Not every man who has an enlarged prostate has symptoms. But if you do have symptoms, we can recommend some fluid and dietary changes. We can continue to wash together. Doesn't mean we always have to do something about it. We can refer you or help you learn physical therapy options for how to strengthen certain muscles and relax certain muscles. And then we have medications. Beyond medications, we have minimally invasive options and then more invasive surgical options. And in order to be able to counsel you on which of these is the best option, we typically need to know what the inside of your bladder looks like, what the prostate looks like, and how big your prostate is. Those are the biggest indicators. So, medication. Many primary care doctors are very comfortable prescribing these medicines, so some of you may be on these medications already. The most common is something called Flomax, which relaxes the muscle at the base of the bladder and in the start of the prostate to help you pee better. So Flomax to get your maximum flow. Tamsulosin, alfuzosin, terazosin, if any of these sound familiar to you, they're all the same type of drug. They all work in the same way. They work well. They help lower those symptom scores. We'll talk about side effects in a second. The second medication, the class is a 5-alpha reductase medication. Finasteride, dutasteride, or Avodart are some of the words that you may, or Jalen, are some of the things that you may be familiar with if someone's prescribed those for you. Those actually work by shrinking the prostate. And they take time. It takes about 6 months to totally shrink the prostate by about 20% to 30%. And a really important thing is, if you are on one of these medications, you must let your doctor know. This medicine in a low dose is actually used for hair growth. So if anyone's used finasteride at a low dose for hair growth, that's also important that your urologist knows that. Because there's a screening tool that we do for prostate cancer, which means we have to adjust that number if you're on this medicine. I'll get into that more in just a second, but important that you let someone know. So why do people not take their medicine? Side effects, and we're gonna get to that in a second, but cost, people don't like to be on medication forever, and the compliance rate after a year is only about 30%. After 4 years, it's about 13%. So while you may be on a medication and you may be very happy, many people do not continue medications long term. So I want you to know about other options in case you're one of those people who just doesn't like the medication or has had side effects. So the most common side effects of the first medication class, Flomax, is dizziness. So going from laying down to sitting or sitting to standing and feeling lightheaded is a very common side effect of Flomax. You can also get nasal congestion or stuffiness. And then something people don't often talk about is something called retrograde ejaculation, which means when you ejaculate, that most of that ejaculate volume goes back into the bladder. It takes the path of least resistance. So people ejaculate, and they ejaculate less volume, and they don't know why, and it's a side effect of this medicine. The second class of medications, that finasteride group, the one on the bottom on the last slide, can also cause some complications of erectile dysfunction, low libido, and some ejaculatory dysfunction. So they're not perfect medicines. Okay, this is a very busy slide that I want you to ignore most of. But what I want to illustrate here is that all of those little pink prostates at the top are illustrating a different minimally invasive or surgical intervention for the prostate. I counted 14 the other day on my sheet for things that I can counsel patients on. So if you fail medication, there's not just one option. Many people have heard about one option, but we actually have several. In-office procedures, minimally invasive radiology procedures, and then we have surgery as well, but lots of different things. So every urologist kind of has their bucket of tools. I have mine for my minimally invasive option, my more invasive option, my completely non-invasive option, and since we can't all be experts at all 14, we all kind of pick what we like to do and what we've become very proficient with. So my next couple slides, I'm going to tell you what I do in those scenarios, but I want you to know that I have 36 other physicians that I work with, and everyone has kind of a different perspective on this. So if something piques your interest for something that you would like to talk about, I can refer you to the right person or tell you who the right person is, or you can come to me and I can refer you over. So we're all knowledgeable about these, even if we don't all perform all of these. So just to illustrate, if you look over at the left, we have, start over here, a normal prostate with a normal urethra and a blocked prostate. We can use steam in the office. We can use clips in the office. We can use little stents or little butterflies that go in and spread the prostate tissue away. We can use lasers. We can use hot knives. We can go through your groin and cut off the blood flow to the prostate. And then we can do big surgical procedures where we leave that orange rind, but take out all the pulp and help you, for people who have really big prostates, and help you pee better. So many, many options. If you're in my office, one of the things that I do most commonly for my non-invasive option is a urolift. A urolift is using, so you can see the prostate there. This is an in-office procedure. I numb up your bladder, I numb up the nerves to the prostate, and then I go in with a little camera and I essentially place a nitinol tab, a suture, and a stainless steel tab to compress the prostate tissue away. So it doesn't remove any prostate tissue, it pushes it out of the way, almost like rubber banding it out of the way. It takes about 10 minutes to do in the office. Many people are good candidates if they're on blood thinners and couldn't stop those for surgery or weren't safe to have surgery because it's an in-office procedure. We do it with a light sedation if we need to, kind of like nitrous gas. And it works really well with no side effects on erections, no side effects on ejaculation. So this is kind of my minimally invasive option of choice. I have a video, I don't think we have time for it, but certainly we can show those to you in the office. But here's an example of before, so this is blocking prostate tissue in the urethra, and then after a urolift procedure. So you can see it pushes the tissue away and creates an open channel to help empty the bladder better. Now, if I thought you needed to remove the prostate tissue, not just push it out of the way, but actually remove it, the most common procedure, and really our gold standard, is a TURP, transurethral resection of the prostate. And if any of you have had or heard of the Roto-Rooter, where people go in and Roto-Rooter, that's what we're talking about here. So this is our gold standard, which means that everything on this slide that's new and minimally invasive, the data all compares to our gold standard, this procedure. So this is done in the hospital. I keep my patients overnight in the hospital and let you go the next morning after removing a catheter. Some people will send you home the same day. But essentially, I'm taking a hot electrode, a hot knife, that will cut and cauterize tissue at the same time to stop any bleeding, and remove the prostate tissue from the inside out. So we don't touch the nerves on the outside of the prostate, but we're creating an open cavity for you to be able to pee better. And this is an example of prostate tissue, and that's the loop, and we just resect the tissue from the inside out. So no cuts, no incision, really no pain. But most people have blood in their urine, and a lot of people have some urgency and some frequency for several weeks afterwards, while that scab on the inside heals. Okay, I'm excited to be able to tell you about this. So there is a new procedure, and it's not really a new procedure, it's new to urology, Austin. Starting this month, we have an interventional radiologist who is joining our group through an interventional prostate center. And this is to offer a new, almost non-super minimally invasive option for prostate cancer treatment. Enlarged prostate treatment. So prostate artery embolization does not go through the urethra. We don't do anything through the penis, but instead we block the arteries to the prostate specifically with little coils or little gel foam. So it's much like a catheter where they go in through the groin, so they numb up the area with a little bit of lidocaine, make a puncture, and then go through the artery, your common artery, in the leg. Sometimes they can use the wrist, and then get all the way down to the small vessels that supply the prostate very specifically with a CT scan. So you're sitting in a seat, laying down in a CT scanner. It blocks the blood flow to the prostate, and you can see before treatment and then after treatment, because the blood flow to the prostate is dying, it shrinks the prostate tissue. It's highly effective. We have 5 to 7 year data that shows that people are very happy with 80 to 90% reduction in their symptoms. And this is all without, takes about an hour in our outpatient center up at the Atrium that's opening this month, just up Mopac. Very low complication rate, no effects on erectile function or ejaculatory dysfunction, and most people return to their normal activity after a week and don't need a catheter. So this is a really exciting new field that we're expanding into to be able to offer something for people who otherwise would not be a good candidate for one of the other procedures or for anesthesia, because you don't need a general anesthetic. So it's exciting. The big thing about prostate artery embolization is that it works better the bigger your prostate is. So you can imagine that the blood flows, and the blood flow to a small prostate, those little vessels are really small, they're hard to find, they're hard to block. The bigger the prostate is, the bigger the blood vessels, the easier it is to block those. So there is a size cutoff for this procedure, but that's why we do all the workup that we do, is to measure your prostate size to tell you if this is a good option or not. So, choosing the best option, it all depends. It depends on your symptoms, it depends on the prostate size, what your bladder looks like, what your prostate looks like. There's a lot that goes into that, but we have many, many possibilities. Okay, so we're gonna switch gears and talk about prostate cancer. So up until now, we've talked about benign prostate and enlarged prostate that is non-cancerous. But prostate cancer is one of the most common malignancies in men. It is the second leading cancer killer in men. And African American men have a higher risk of mortality and death from prostate cancer. There's a genetic component, there's familial, so if you have first-degree male relatives that have had prostate cancer, you're at increased risk for that. If you have had prostate cancer, your male relatives are at risk for prostate cancer and should be screened, your kids, your grandkids. And we screen with a blood test, which many of you may have had, called a prostate-specific antigen. It's a molecule that circulates in the blood that is very specific to the prostate. And it's very specific, but it's very sensitive, but it's not very specific. What I mean by that is it can be high for a lot of different reasons. If it's high, it's a good indicator something's going on, but it could be for a lot of reasons besides prostate cancer. Now, some of you may have had a rectal exam, and that is a good indicator to help us gauge size and how smooth or normal a prostate is, but only half of nodules that we feel on prostate exam are actually cancer, and most men with prostate cancer don't have a nodule, so it's not perfect. And in fact, our most recent guidelines have actually moved away from doing this exam. Many urologists still do it because we feel it's necessary, but it's no longer in the guidelines. What is a PSA. So, we say that a PSA, or a prostate-specific antigen blood level above 4 is something concerning that we need to investigate further. But that is age-adjusted. So the older you get, the bigger your prostate is, the more PSA it makes, and so we have to take all that into consideration. And like I mentioned, inflammation, an enlarged prostate, recent manipulation, intercourse, sitting on a bike or a motorcycle, hitting your prostate against it, any of those things can artificially elevate this number. So we have to take it into consideration. So, the American Urologic Association is our guiding body. That's where we follow our guidelines. And the recommendation is for men who are going to live more than 10 to 15 years of life expectancy that we check PSA plus or minus a digital rectal exam every 1 to 2 years starting at age 55. Now, they also recommend that we do not screen below 40 and above 70. And the reason why is because you'll see in a second the next step, which is a biopsy. And we have actually diagnosed prostate cancer or caused harm from prostate biopsies more often in those populations than we have saved people from prostate cancer. So there, you may have heard all of the drama over the last 10 years of, do you check a PSA, do you not check a PSA? These are the current guidelines. If you have a family history of prostate cancer, or you have it, your children or your grandchildren should be screened at about age 50, so a little bit earlier, but we check it every 1 to 2 years, age 55 to age 69. And then it's a shared decision between us and you about how long we check it. If you've had prostate cancer, we're gonna check it every year for the rest of your life. At some point, we may decide we're gonna stop checking it in people who haven't had prostate cancer. and generally that age is 70, but again, that's really patient dependent. So if your PSA comes back high, what do we do? Well, PSA, as I mentioned, is not perfect, so we need a confirmatory test, and that is a prostate biopsy. So that's where we use an ultrasound through the rectum to see the prostate and use a tiny little needle to take 12 samples of tissue from that. Now, oftentimes we'll get an MRI, if you're able to get an MRI beforehand, and see if there's a lesion that we can specifically target. But we still need to take samples of all this tissue. And we are looking for prostate cancer that could kill you. So there are many types of prostate cancer, and this is a controversy, many types that are low risk that will not cause a problem. Most people die with prostate cancer, not of prostate cancer. You have probably heard that. So low risk prostate cancer, oftentimes we now observe, in fact, that's the consensus, is to observe that by repeating biopsies every several years and checking your PSA about every 6 months. If you have a higher risk prostate cancer, intermediate risk or high risk prostate cancer, we do something about that. And our job is to find the people that are at risk for dying of prostate cancer and treat them. The two most common ways that we treat prostate cancer are with radiation or with surgery. So radiation, this is an example of a radiation vault. And here at Urology Austin, we have actually one of the top rated radiation centers in the country. For our size of patient population, we're number 1. For the whole country, we're number 7, so we're quite proud of that. But the whole goal of Radiation Center is to target, of radiation, is to target just the prostate, not the rectum, not the bladder, not any of the surrounding structures that can cause harm, but just the prostate, and they're really good at that. Most prostate cancer that is treated surgically is now treated robotically. So this is an example of the Da Vinci robot, where we use a console and an assistant and a robot to perform essentially microscopic movements to remove a prostate. And because of this, we can use very small incision sites. They're each less than they're about 1/2 inch incision sites to remove a prostate gland for prostate cancer. Okay, so we've made it through prostate. We're gonna move on to erectile dysfunction. So, to understand erectile dysfunction, you have to understand erectile function and how it works. Erectile function requires several different things. It requires an intact nerve that can start the cascade to cause increased blood flow to the penis. So typically stimulation, intact nerves, and intact blood flow. And you want blood flow to go in without leaking out. And that's what it allows people to sustain a firm erection. So this is a cross-section of the penis. It shows erectile tissue, and then here's your urethra. So this is where you pee, and it's surrounded, it has some vessels, blood vessels, and some nerves. So this is in the flaccid state, this is in the erect state, and you can see all these little bodies expand, and they expand because of different material that is circulating through the blood. So what can affect this? Well, anything that affects one of those. So if you've had prostate cancer and your nerves have been affected, that can affect it. If you smoke and you have less blood flow going to the penis, that can affect it. If you have diabetes, diabetes can affect the nerves. Some people you may know have peripheral neuropathy, tingling in the nerves. That's small nerve disease. So that can also affect erectile function. So can high blood pressure. So the higher your blood pressure, the harder the arteries become, the less blood flow gets to the penis. So stopping smoking, maintaining a healthy weight, increasing exercise, as I mentioned, weight loss, all those things can also improve erectile function naturally. So erectile function is the ability to achieve and maintain an erection. So be able to get essentially rigid enough and sufficient for penetration or whatever you desire to do, and to have durability, to make it last as long as you need it to last. 1 in 5 Americans greater than 20 years old has erectile dysfunction. It is incredibly common. That's 30 million American men. So like we talked about, the main causes of this: blood pressure, so anything that has to do with the blood, diabetes, and medication side effects. Like I mentioned before, we may put you on a medicine for your prostate, and it may have side effects of erectile dysfunction or ejaculatory dysfunction as well. And so that's our job, to help counsel you on those things. Okay, a busy slide that I'm going to keep coming back to this. So what are our options for treatment of erectile dysfunction? Because we can't always undo some of those things. I can't always undo diabetes, even if we can control it, or even undo the damage from having high blood pressure, even if we can control it. So generally, we start with medication. So you may all have heard of Viagra or Cialis. Those are the two most common oral medications that we use for erectile function. They're really effective. About 70 to 80% of people do really well with this. And we can increase the dose as we need to. So it's important to remember a couple things about these drugs. One is that they work with stimulation. If you're sitting on the couch with a bowl of popcorn, it's not going to do anything. So you have to be stimulated, or you have to stimulate yourself. That's key. The second is that Viagra specifically is absorbed by food in your stomach. So if you eat and then take your Viagra, it's not going to work. It's certainly not going to work as well as it would if you took it on an empty stomach. So Cialis is a little bit different. Cialis stays in your system for longer. So you don't have that problem with Cialis, but you do with Viagra. So if you are taking Viagra, take it either 30 minutes prior to a meal or wait at least 2 hours after a meal. And that's how you're going to get your best efficacy with Viagra. Some common side effects: facial flushing, headaches. Some people get some stomach upset. With Cialis specifically, it can cause a little bit of blue tinted vision. So some people notice that their vision is a little bit blue. It's really important to know you cannot take these medications with nitrates. If you take nitroglycerin or nitrates for your heart, you can't take one of these medications. It will severely affect your blood pressure. Similarly, if you did take one of these medicines and you're starting to have chest pain, you need to let your doctor know before you take those. There's one other thing I wanted to mention about these. I'm sure it'll come back to me. Okay, so, yes. The most serious complication, and not common at all, but the most serious complication is something called a priapism. A priapism is a painful, firm erection lasting for more than 4 hours. It is rare, but it is not comfortable. It is painful. You have to go straight to the emergency department, and we have to put a needle in your penis and suck the blood out. It is terrible. So when someone gives you a dose for one of these medications, follow the directions, because if you give yourself too much or you take too much, that's the risk. Again, super rare. I'm not trying to scare you from these medicines, but something that you need to know. Okay, so coming back. So I have a lot of patients that say, I tried these medicines, they didn't work for me. First thing I said is, are you taking it with food? A lot of people are. But if it still doesn't work, we can combine those or instead do something different, like a vacuum erectile device. So this is an erectile device, much like vacuum suction, that causes pressure on the penis to incite an erection. And then you place a ring, a constriction band at the base of the penis to maintain that erection. They're about $300 or so. Sometimes they can be covered, oftentimes they're not covered by insurance. But these we can order through our office. You can also order them on Amazon. And they are combined with medication, work really well. The other strategy we have is an intraurethral suppository. So it sounds uncomfortable, but we can use a gel or a little suppository, put it in the tip of the urethra, and that will cause an erection. Some people get a little bit of burning in the urethra, so we don't prescribe these as often in my office, but I do have patients on them that really like it. So if all of that fails, we also have intracavernosal injections. So these are injections into the penis of an erectogenic medicine. So this medicine, when you put it inside the penis, almost undoubtedly causes an erection if we give you the correct dose. Now we need to work on that dose sometimes. It's not one dose fits all. So we actually test you in the office to get the right dose. You use a very, very tiny baby needle, like an insulin needle, and that's pretty painless. Goes directly into the erectile tissue. You give yourself a dose of medication, and about 5 to 20 minutes later, you have a firm erection, and then that goes away. Same risk as a painful, firm erection that needs to go to the hospital if you give yourself too much, but that's why we test it in the office to find the right dose for you. Side effects of this: prolonged erection, scar tissue building up, and if you're on blood thinners, you can get some bruising at the site of injection. Okay, one other thing I had not mentioned yet is this bottom left corner is a picture of something called LIST, low intensity shockwave therapy. You may have heard about this, it's all over the radio. So this is essentially ultrasound providing shock waves to the penis. So it's non-invasive. It is not yet endorsed by the American Urologic Association. And the reason why is because we don't have long-term good data on it. At about 12 months, the data is really good that it's a non-invasive way to improve erectile function. But beyond that, it looks like most of these men need to go on to something else. So maybe it buys you some time. It can be expensive. Insurance doesn't like to cover it. But it is a non-invasive way. And we do have a LIST machine in, I think, our Round Rock location. And so that's something that if you were interested in trying, certainly it's an option. We offer that as well. Okay, finally, if all these things fail, there's something called a penile implant. And so a penile implant is exactly what it sounds like, which is an implant into the erectile tissue. It's a cylinder that fills with fluid, normal saline, that sits in a little bulb behind your pubic bone. And when you're ready to have an erection, you use this, you squeeze this little device, and it transmits the fluid from the reservoir into these cylinders to cause an erection. When you want an erection, it's on demand, you pump it up. When you're done, you push a button and it releases all of the fluid and you have a flaccid penis. So it's been on the market for over 30 years. It is a very, very effective way to provide erectile function if all the others fail. I don't perform the surgery anymore, but I have 3 partners in my office and many more at Urology Austin that do, if you're interested in something like this. Okay, finally, incontinence. How are we on time? We're cutting it close. So, we're gonna be as thorough as possible, as efficient as possible. So we're gonna talk about the bladder and leakage. This is one of my passion projects. I love the bladder and bladder function. I think there are so many people that have incontinence, that are living with incontinence, leaking on the way to the bathroom, and don't really understand exactly what's going on. And we can help you figure that out and most likely significantly improve that problem for you. And most people don't know that we can. Okay, so to understand how the bladder works, this is a picture. As I mentioned before, the bladder stores urine. So what should happen is your bladder you should be able to walk around. Your bladder should fill with urine passively through the holes that go from your kidney down to your bladder, and you should be able to hold your urine until the point where it gets full, sends a signal to your brain through your spinal cord that says, I'm ready to pee. And then you should be able to go to the bathroom, hold your urine all the way to the bathroom, sit down or stand up, give yourself permission and completely empty your bladder. That's the way that it should work. And that is relying on a sphincter muscle at the base of your bladder, holding urine in, and on your bladder being nice and calm and not being spastic or overactive. So there are 3 different types of leakage. There is leakage with coughing, sneezing, laughing, jumping, or exercise. So that's exertion, pressure on the sphincter. That's called stress incontinence. A completely different type of leakage for a totally different reason is called urge incontinence. That is your bladder muscle spasming when it shouldn't spasm. It should be nice and relaxed. When it contracts, it causes urgency and makes people leak. Totally different problem. And then there's actually a third problem that we see more in men, which is called overflow incontinence. That's when your prostate's so big that you can't empty, or your bladder doesn't work and you can't empty, and your bladder fills up so much that your cup overflows. So you leak urine because your bladder's so full it's just spilling over. You may not know what type of leakage you have. You may just know that you leak. But we can figure those things out with questions and very simple tests in our office. 43 million men suffer from urinary incontinence, 17% of men. And the rates of incontinence after a prostate surgery are up to even 70%. Now, if you had a prostate surgery and you leak with coughing, sneezing, laughing, that is the most common reason. And that is because of the sphincter. That's because of the surgery for prostate affects the sphincter on occasion. So that's a specific example. We're going to come back to that in a minute. But right now we're going to focus on urge incontinence or overactive bladder. So 1 in 6 adults has overactive bladder. Symptoms, urgency, frequency, gotta go right now, leaking on the way to the bathroom, waking up at night to pee. All of those things are very characteristic of an overactive bladder. So when you come to our office, the first thing we're gonna ask you is, how much caffeine do you drink? How much alcohol do you drink? Do you drink up until bedtime? And we're gonna make some recommendations based on those things to try to help you modify your diet and your behavior to try to improve those symptoms. But we also have medicine. We have 2 different drug classes of medications. And the medications work to bind to the bladder muscle to relax the bladder. That's the whole goal. We're trying to relax the bladder here. Some of the medicines, which are older medications, cause dry eye, dry mouth, constipation, and there is an association with some memory loss or some cognitive changes. So in general, in our office, if you're over the age of 70, we don't even really discuss those because of that side effect. But drug companies love that. They love for us to try them first because they're cheaper. So we have to fight that battle every day. Now, there's a second type of medication that doesn't have any of those side effects. And there are 2 medicines in that drug class, and one of them just became generic. And so those also work to bind to the bladder muscle, but do not have any of those side effects of dry eye, dry mouth, or constipation. They are very safe. In fact, one of them has no drug interactions and no complications or side effects. So it's very safe. So, those may be a good option for you. But if they're not, or if you've tried those medicines and they didn't work for you, we have 3 other options for overactive bladder treatment that work very, very well. So the first is essentially like acupuncture to your leg. So you come into the office once a week for a 30-minute session, and we hook up a tiny baby needle to the nerve that sits on your ankle. And that signal travels back up to the spine, to the 3rd sacral nerve, the nerve that goes to the bladder, and helps calm your bladder down. It takes about 4 to 6 weeks to notice a benefit, and you come in once a week for 3 months. So it's non-invasive, but it is a lot of office visits. People get about a 60 to 70% improvement in their symptoms with that treatment. The second treatment that Cindy and I do all the time, multiple times a day, is Botox injections. So Botox, you may have heard about. People use it for migraines, use it for wrinkles, use it for spasms. We use it in the bladder to calm the bladder down. It lasts for about 6 months at a time. It's an in-office procedure. You come in, we put some numbing medicine in the bladder, we go in with a little camera and we inject Botox. It takes about 15 minutes for your bladder to totally numb up. The procedure takes about 1.5 minutes to 2 minutes to inject this Botox, and then it lasts for about 6 months. Now, we make sure you can empty your bladder because one of the risks of Botox is that we over-relax your bladder and it's harder for you to pee. So we talk about that in detail. That happens about 7% of the time. So 93% of the time, people have no problem. And they come in every 6 months, they put some Botox in their bladder, and they're on their way. 85% of people have success with that treatment. The third treatment that we do a lot of is called an InterStim. An InterStim is like a pacemaker for the bladder, or like a spinal stimulator. So the way that it works is it is providing current through a little electrode to the nerve that goes to the bladder in the bowel. And it is FDA approved for 3 things: urine leakage or overactive bladder, incomplete bladder emptying, and fecal leakage. So if you have fecal leakage, it works 94% of the time. Urine leakage, 84% of the time. So this week, the first step, I think I have a picture here. Yeah. Okay, so the first step Cindy does in the office with a light anesthetic, so lidocaine, just local anesthesia, will numb up the area over the spine and place 2 little wires down next to the nerve that goes to the bladder and the bowel. And then you walk around with those taped to your back for 5 days. And for 5 days, you're keeping a diary and we're recording. Are you better? Or do you have less leakage, less urgency? 5 days later, you come back to the office, we take those wires out, we take everything out, and if you're better, I take you over to the surgery center with a very light anesthetic, kind of like a twilight you would use for a colonoscopy, and I implant this little battery pack connected to this wire. Now, the pathway I'm talking about right now is that small sheet, and I know some of you didn't get a copy of it, but the small sheet, that handout, refers to the pathway of everything I just discussed. There is one error on that sheet. That sheet is outdated. We used to implant these batteries, and they would last for 3 to 5 years. Now, when we implant these batteries, they last for 10 to 15 years. So with a simple procedure, with Cindy and then with me, if this works for you, we can implant something that lasts for 15 years to help you with your urine leakage or your bowel leakage, which is pretty impressive. Okay, one last thing to touch on here, stress incontinence. So backing up, if you leak with coughing, sneezing, laughing type of leakage, or you pick up something heavy and you leak, or you go from sitting down to standing up, and that's the only time that you leak, it's probably stress incontinence. And that's probably because of a weak sphincter or pelvic floor. So we can recommend pelvic floor physical therapy, trying to strengthen your sphincter. There are also options such as penile clamps to keep you dry, or even condom catheters, so external devices that collect urine. But we have 2 other surgical options that are helpful. One is a sling that goes underneath the urethra. It's a piece of mesh to help compress the urethra so that you don't leak. The second is something called an artificial urinary sphincter. This is very similar to that penile prosthetic, where we have some fluid behind your pubic bone, something in the scrotum, and a little donut around the urethra that is filled with fluid and keeps you dry. And when you're ready to pee, you push a little button, it relaxes, you pee, and then about 90 seconds later, it closes down passively on its own. So if you have severe leakage after like a prostate surgery or a prostatectomy for prostate cancer, that is a highly, highly successful option for you. Okay, we made it. Just a little bit over time. I am gonna get, do you want the microphone? Thank you all for listening and your attention. I really appreciate it. As I mentioned, there are several more men's health issues that I'm sure that you wanted to hear about. Low testosterone is very common. Penile curvature, called Peyronie's disease, also incredibly common. I wasn't able to touch on those today, but certainly things that we can talk about in the office, or I can refer you to one of my partners who treats those things. So if you have any of those questions specifically, feel free to catch me at the end and we can discuss and I can tell you who's best to help you. But hopefully this was at least some insight onto some of the most common issues.
Anybody have questions?
Yes, and it's one, I think more specific, but it's maybe a little different. Well, right now, what I've got is actually a tendency to get urgent sometimes and not others, but they said that apparently the valves of my veins are weak and I'm tending to swell and retaining fluid, and that seems to be the only cause. Sometimes, in a rare occasion, you might be going every hour, although I don't have that very often, but it's possible. But they said, it's trying to expel that fluid, not because the bladder itself may be weak. I've probably been diabetes for 57 years. And right now, it's manageable. If I get up, I can usually get there, but occasionally it'll get urgent and I'll spill out a little because of that pressure and I've had diabetes for so long, it's probably worn out the valves of the veins and there's more fluid. and but no other problem. So my PSA is still 1 at 77.
That's a good PSA for 77.
Yep.
So,
Like it's never enlarged. I think it's all the swelling and also the diabetes.
you bring up a very good point, which is that there are plenty of other issues that can cause urine problems. So, things like sleep apnea, we didn't touch on that, but that makes people wake up at night to pee. Diuretics, if you're taking medication that mobilize fluid, or if you have swelling in your legs. So some of the common things that will help, that's easy, compression stockings, raising your feet, those types of things, they can help mobilize fluid earlier. But certainly, we can check on the others to make sure that there's not another issue.
Probably, if I'll talk with that's okay, I'll talk with my primary care doctor, and I can talk with Patty and there, if they're aware of it. I am using compression stocks, and that sometimes helps. And also I've got post-polio, and a weaker leg takes another leg, and all that may be even aggravated. But I think diabetes plus.
Is there a quick fix for every time I hear running water, I have to go pee?
So that is a symptom of overactive bladder.
Telling me.
Yeah, exactly. So that's one of the most common. That and like getting to the door and you feel fine, but then you hit the door and all of a sudden you have to really go. The turnkey syndrome is what we call that. So yeah, so that's a symptom of overactive bladder. So what I would say is to start with the easy stuff. Make sure that you're peeing every 2 to 3 hours. You pee on demand, make yourself pee so that your bladder isn't full and then you're trying to rush to get there. You want to stay on top of it. But there's, so maybe not a quick fix, but mini fixes if you're interested.
I would assume that most of the procedures are covered by Medicare.
Yes. The procedures that are not covered by Medicare are few and far between now. In the last 3 years, I've seen some that used to not be covered become covered. But yes, almost all of them are. And there's at least one in every category for them, yes.
Is that crypto, whatever?
Cystoscopy,
Yeah,
that's covered.
okay.
Oh, yeah.
I'm gonna put it in order for one.
We're happy to accommodate.
There's an article today in the Wall Street Journal about the dangers of low testosterone treatments that are being offered widely. Can you comment on
The dangers of low testosterone, or the danger, I didn't see the article, or the dangers of the treatment?
dangers of the substitute testosterone that they are offering?
So it's important, what I would say is that it's really important to find a reputable source for testosterone. So testosterone is highly regulated, and there's some that's FDA approved, but you'll also find a lot of bioidentical or compounding pharmacies, which is maybe what you're referring to. So what you need is a pharmacy that can be trusted, that you know is regulated and approved, and that provides the dose of testosterone that they say that they're giving. So there are several risks with testosterone. There are several benefits of testosterone for both men and women, specifically on bone health, on cardiovascular health, on longevity, mood, all those things. So it's all about finding a reputable pharmacy. We supply testosterone. We also provide testosterone pellets from a reputable company. But certainly there are several men's clinics that, well, let me back up and also say, we also do the appropriate testing. So if you're going to be on testosterone, you need your blood levels checked, your PSA checked, we need to think about your liver. There's several things that we need to do to make sure that you're safe on testosterone. The danger with testosterone happens when those things are neglected, and it is a highly profitable, it's a profit source for a lot of clinics. So you'll see a lot of men's clinics. So what you want is people who know what they're doing, who use a product that they know, and that they're watching you really closely to make sure that none of the harms of testosterone are affecting you. That's not a perfect answer, because I haven't read that article, but.
You mentioned a
drug, an OTC drug that you can take for urgent incontinence that has no side effects. Could you name that drug?
It's not over the counter, it's a prescription drug, but it's called Gemtesa. Gemtesa. There are no validated in clinical studies safe drugs to take over the counter for overactive bladder. Most of the benefits that I could recommend that are not prescription based are behavioral or physical therapy. But that medication is the medicine that has really no drug interactions or no side effects. The only side effect is its out-of-pocket cost if it's not covered by your insurance, which is ridiculous.
Well, looks like she's answered all her questions. Thank you so much, Dr. Sassler.
See you in a couple weeks for the women's talk.
And if you all would fill out your evaluation forms for us and hand them in, we'd really appreciate it. Thank you.